care, the best medicine is the one that fits the patient and not the rankings. So let's get into the study. What are these obesity drugs? What is this study telling us? I'm joined by Dr. Amitabh Parthi, Internal Medicine, Fortis Memorial Research Institute, Gurgaon. And I'm also joined by Dr. Neeraj Kumar, Senior Consultant, General Medicine, Sharda Care Health City. I thank both of you, but let me straight away go to Dr. Amitabh Parthi. Sir, different results, different drugs. What's the big picture, sir, that is emerging from the analysis that has come out?
So at present, we have another issue with this. Apart from what the Western world thinks, we have to think of the Asian population, where we think of the lean fat Indian. We say we are sarcopenic obese, that means we have less muscle and more fat. So we need to address both. So our first situation is we want to lose fat and preserve the muscle. That is the first part. The second one is what sort of protection that we can offer to an obese patient. So a lot of customization will need to be done in due course in order that we can look at patients who do not have a risk of heart disease and those who are looking only at weight loss. So we look at two different varieties of drugs, one which would look only at the weight and look at protection in due course, or those who already have a risk which is associated with weight, and we need to address them as well and look at them with a perspective of the Indian, the percentage of Indian individuals who have more of truncal obesity, less muscle and more of fat. So we look at different drugs in different perspectives. A drug like Mounjaro or Tirzepatide is very effective, typical in younger individuals or individuals who could exercise, where probably weight and diabetes are the only indications for that weight loss. Whereas individuals who are slightly more elderly or probably who have a high risk for cardiovascular disease, renal disease, probably in those situations, we would prefer a drug like Semaglutide. So customization of the molecule, depending upon the individual, sustaining the dose, preserving the muscle, and then taking the patient through the journey from fat to fit is what would be vital in the Indian setting.
Okay, let me go across to Dr. Neeraj Kumar. So, what is the big picture? What is the message? You know, a lot of people are rushing for a quick weight loss. They think it as a nirvana, thinking that, you know, nothing has worked on them. At least these drugs will work. But these drugs are showing very different results. Nothing is 100%.
No, we are searching for anti-obesity drugs since 1999. We got orlistat, lipase inhibitor. After that, we got many things. We have everything in our pocket right now. But we have to think about few facts like diabetic versus non-diabetic, patient with other conditions. Can we replace normal physical activities with these drugs? Can we replace balanced diet with these drugs? Everything needs to be in consideration. And what about our developing economy, we have to think about cost benefit also. That is also important. Till now, I have many patients like this, but I'm not able to tell them how long they should continue it, the duration, when they can replace it with physical activity. There are so many things to be answered right now. But yes, these medications are big hope for many populations. They have very good results. They have very good cardiac mortality.
Okay, but Dr. Amitabh, there are a lot of concerns which people have. Do they have long-term impact on important organs like heart, kidney, liver? Can these drugs impact them, sir?
Fortunately, it is the other way around. These are, we say CKM, they are cardioprotective, renal protective, and they are metabolic regulating agents. So they would improve cardiac functions, prevent cardiac events, improve kidney functions, improve the kidney function rates. They will in fact regress the fatty liver and produce improvement in the metabolic correction. So those individuals who are suffering from in fact sleep apneas or those with PCOS or such individuals will also be benefiting. So it produces nearly a comprehensive holistic correction of the metabolism. Not only weight is an issue, but for these individuals, the other comorbid conditions that the obesity is driving, all of them will get corrected. So in fact, the drug is as safe as you can continue using the drug even if the GFR, the kidney function rate, drops to about 25%. The drug is safe for individuals who move from normal liver to fatty liver, even up to the level of cirrhotic livers. You can go on using the drug until the time
Dr.
the patient
Mamata,
decompensates.
how do you divide this classification of drugs? Who should take which drug? You know, I have a lot of friends, they said, okay, this drug didn't work, we shifted to Manjaro. How do people decide that? How do doctors prescribe that, sir?
See, the classification of both the drugs, first of all, the molecules are different. They're not similar. Mounjaro contains two molecules. It contains GLP, glucagon-like peptide, with GIP. It contains two molecules. Semaglutide or the Ozempic contains only the GLP-1. Now, GLP and GIP combination, Mounjaro, has nearly a 30% higher weight losing propensity and probably maybe a higher HbA1c losing propensity than semaglutide. So if we look head on between Mounjaro and Ozempic, probably the weight loss is 30% higher with Mounjaro. But what is important is not the weight loss alone. Sustaining the drug on the patient, tolerance of the drug, preserving the muscle mass, and maintaining the nutritional status of the individual is very important to look at the quality of life that you're offering to the patient. So maintaining the drug at a particular dose escalation is warranted. We would not administer an escalated dose if we find the patient is not tolerating it, or he's going into nutritional compromise, or he's having too much of a gastrointestinal symptoms like nausea, vomiting, so on and so forth. So initiating the drug is one story. Maintaining a dose, sustaining the drug, tolerance of the drug, and preserving the muscle, very, very important for all who are using GLP, GIP, is preserving the muscle mass. We have to understand there is a protein requirement that the individual requires. There is an encouragement of resistance training. We have to encourage, once there is a weight loss, it's not only fat that is lost. Out of all the fat that is lost, there is a 10% muscle that is going to get lost. So unfortunately, there has to be a contribution. These are all adjuncts, add-ons to lifestyle modifications. So we must understand you have to add on this to a lifestyle correction.
Okay, Dr. Neeraj, tell us, when do you guys decide that now this gentleman or this man or this woman needs to be on drugs? You know, generally the entire thing is, can you change your diet? Can you change your lifestyle? Can you change your exercise schedule? When is that inflection point when it is decided, now you need to be on this medicine, weight loss medicine?
Obesity is a very vicious phenomenon. We can tell someone to walk, but if that individual's BMI is 40, his both knees, they are paining so much. His cardiac activity is reduced. I cannot tell her to go around for half an hour, jog or go to gym. It's very difficult. Then my thing is, I'll tell the patient that you go for the drugs. Now you have only one choice left. First, next, many patients, they used to come. If the patient is cardiac, these drugs, they do wonder for them. If diabetic patient is there, their results are so good. If patient is tolerating these drugs, of course they are better than anything. But it is very difficult. Some patients, they don't tolerate, or they are not, patient compliance is not very good. Then these drugs, you cannot expect a very good result with them. Another, there is a regular follow-up. Yes.
No, complete yourself, then I'll go to Amitabh.
Yeah. There will be required very regular follow-up, prolonged duration of treatment, and routine checkups. These are required, and individuals should not have the contraindications with these drugs.
Okay, Amitabh, you wanted to come in?
Yeah, we must understand this from the Indian perspective. We are different, not only in terms of the weight, but where the weight is located, where the fat is located. So for us, as unlike the Western world, BMI may not be a standard for obesity management.
Really?
We must understand BMI alone is not the standard. For us, what is the standard is the waist circumference, his waist to hip ratio. And I'll give you a very simple formula. The waist circumference should be 50% of the height in centimeters. If your height is 150 centimeters, your target of waist should be 75. I'll give you another example. Internationally, the standards
You know,
at
Dr.
which the
Amitabh,
body
that's the
mass
first thing
index-
I'm going to do when I go home today. Really,
must
you
try
have
this.
killed the
You must
entire
try.
BMI thing. That's the first thing I'm going to do. Map
BMI
myself
is not a
vertically and then
marker.
horizontally.
Exactly. That is what we want to encourage and tell the people, that don't look at the weight alone. Look at the waist. Look at the truncal obesity. Look at what it is. That is the one that's driving the disease. The blood pressure, the diabetes, the
But
heart
why do you
disease,
say
the
that?
stroke.
Why is it driving the disease, sir? Can you just break it down for our viewers?
All right. Okay. So, unfortunately, you have to understand the South Asian gene. We have a gene which creates a lot of insulin resistance. We are not able to recognize insulin as much as the Western world. For example, if you look at the formation of an Indian obese individual, he'll be typically truncally obese. Whereas in the Western world, he is going to be wide like this, not like this.
Yes.
Correct?
Yes.
So the truncal obesity is the one that drives. For example, what happens is, once the insulin receptors or the sensitivity to insulin is reduced, the body starts accumulating fat at age 20, age 30. By the time you reach age 35 and 40, you are creating more insulin because the body is not recognizing the insulin. And the fat that you've collected around the skin, in the waist, then starts getting accumulated in the system. It gets into the liver, into the heart, into the blood, into the kidneys. Now this organ or visceral involvement with fat, the visceral adiposity as we call it, is going to further drive insulin resistance, is going to further refuse to identify insulin. So the insulin effect will reduce, the body will accumulate more fat. So insulin resistance drives obesity, obesity worsens insulin resistance, will further drive obesity. This is the Indian setting. So in India, we have people who are fat.
So despite exercise, you will not be able to burn fat.
No, you will not be able to burn fat. Exactly. Despite your exercise, you will not be able to burn fat. Most of the therapies that we describe nowadays are an adjunct to the correction of lifestyle that we have added. But please understand, there are individuals who, despite lifestyle modification, are unable to lose weight. The problem there is insulin resistance. There is genetic factors in the Asian population which are driving obesity. We must understand, correcting the metabolic corrections, whether it's diabetes, high cholesterol, thyroid,
Amitabh, is
PCOS
cortisol
alone may
also
not help.
important, or is just a Twitter phenomena? Cortisol, stress and visceral fat?
Sir, no. The visceral fat is the one that's the most vital of all the obesity parameters. It is the one that is going to drive the disease process. It is not the physical obesity alone. It is the what you see, what is the invisible fat, we call it, unfortunately, is what you see is only the proportion. But what we don't see is the more dangerous, more notorious, more toxic fat is the one that is circulating in the system. The heart, the liver, that is where the problem is. That's where the strokes are driven, the heart attacks are driven, the kidney failure is driven, the sleep apnea is coming in because of weight alone. But heart disease, stroke is coming from the visceral adiposity, the deposition of fat inside the system.
Okay. So, Dr. Neera, how do we kill the visceral fat?
Yeah, that is the first thing is the physical activity. Next thing, we can reduce our fat intake with a good dietary habit. And after that, we don't have any choice. We have to go for the medications.
Medication.
This is what we have. Yes.
There is no other way to reduce the visceral fat?
We should go for physical activity first, then dietary intake, and then medicines. These three things.
Amitabh, is visceral fat linked to cortisol and stress?
The obesity can drive the cortisol. Agreed. Stress can drive the cortisol. But can stress alone drive obesity? Unlikely. The way to correct visceral fat would be, one, to use a calorie insufficient diet or calorie deprived diet. If you are running at 1500 to 1800 calories, do a calorie deficit diet of 1200 to 1500 calories. Start physical activity with actually about 60 to 90 minutes 5 days a week. change your dietary plan to increase the protein intake of about 50 to 80 grams as you advance in age. An Indian diet, for example, carries only 40 grams of proteins in a day. Okay. Once you advance more than 40 years of age, you require about 1 gram. You require about 80 to 100 grams of protein per day. So you need to increase the protein. Once you increase the protein, your stomach would fill earlier. You would be much better. Have a high fiber diet. Encourage the hydration. Better sleep habit. These are the ones that will help in improving the visceral adiposity.
You know, it's such an important discussion, but I'm really falling short of time. The entire issue is you can make up with the protein shakes, but the protein shakes themselves are ultra-processed food, and ultra-processed food themselves, you know, they have a direct impact on your body. So how do you take so much of protein? Then you need to have a sort of a non-vegetarian diet. Even if you take that non-vegetarian diet, it entirely depends on how you cook that protein, because, you know, we are curry people, which means that, you know, there has to be some sort of an oil. The grill and the over the fire element is less. But I know, but this, you know, this conversation can just move on. Just
one sentence.
Tell me.
Sentence. You cannot replace anything with natural things. It's not possible to replace nature.
Oh, I completely agree with you. I completely agree with you that, you know, you can't do that. Even protein shakes, people like it. They can say natural, plant-based, yeast-based, and the whey-based. But it is still an ultra-processed thing. And anything which is ultra-processed will have a direct bearing on the body. Which way, it can have it today, it can have it 10 years from now. And I personally feel that a lot of experiments have taken place on people. I remember dalda coming into the Indian food system. It took 30 years for it to be removed. But thank you both of you for such a riveting conversation on these drugs which cure obesity or treat obesity. But to all my viewers, you have to go to the doctor first, not to the chemist to get these drugs. And it's time for a short break, but don't go away, because after the break, when I come back, we're going to talk about something which is very important, and that is about Punjab. And our political party is using a film to revive themselves.
Meet the tomorrow today. ICFI is the bridge between tomorrow and today. Bridge between aspirations and accomplishment. Bridge between I wish to I can. I will remove the gap. Welcome to the I. I am ICFI. Belief called I. I can fly above imagination.
ICFI.
Why has Iran stopped the traffic in the Strait of Hormuz?
They want to attack us, they want to target us, so we have to defend ourselves.
They are punishing countries outside the region as well, like India, and like countries in South and East Asia.
The big problem that they've created now is the closure of the strait.
Ultimately, the main purpose of this exercise is, frankly, to prevent Iran from obtaining a nuclear weapon.
Whenever they've got involved in a war on behalf of somebody else, there isn't been just an altruistic purpose.
The controversy over Diljit Dosanjh's Tara Satluj is no longer confined to cinema. It is no longer confined to the coffee shops. What began with the question over the film's abrupt removal from Z5 has now evolved into a wider political and religious issue in Punjab. The Shiromani Akali Dal has announced a statewide campaign to screen the film, while Akal Takht has called for a special ardas to honour those whose stories were documented by human rights activist Jaswant Singh Kharla. The larger political question now being asked is,